Thanks to everyone for joining us for this weekly IDMP series here at the Broad, where we're turning our attention to COVID-19. We apologize for the little bit of late starting time, just some technical glitches. But we're thrilled that you've joined, and we're even more thrilled that Michael Mina is here to talk to us today about a topic that probably everyone has read extensively about in the news, and that is the role and need for diagnostics to confront this pandemic. Who would have thought that we would have so many conversations about nasal swabs? At any rate, Michael, as many of you may now know, because he's really been kind of one of the leading faces confronting this, and certainly here in the Boston area, is a assistant professor at the Harvard School of Public Health. He is also a pathologist and is the associate director of the microbiology laboratory at the Brigham and Women's Hospital. And so without further ado, I'll turn it over to Michael and make sure we leave lots of time for questions.
So I thought I would take a bit of time today to get people, some people, I think everyone obviously knows all about this virus and how it's been impacting around our community. Now, I thought I'd just kind of walk back in time very briefly to sort of get caught back up to where we are now, and then discuss some of the testing. And well, first I'll introduce myself. So I'm an assistant professor of epidemiology. I'm also an assistant professor of immunology at the Harvard School of Public Health, Deb mentioned. And so my lab generally is in the Centers for Communicable Disease Dynamics at the School of Public Health. And so we've been, a lot of our work started with really studying the epidemiology, and then because I also am a clinical director in the medical microbiology lab at Brigham and Women's Hospital, the story that I'll tell kind of starts with epi and then really moves into testing, which is what most of this is going to be about. But this epidemic started, of course, in Hubei province in China. And I just want to show this slide here. I think probably a lot of people on this call have already seen this. And the reason to show this slide is to just show how swiftly the Chinese acted in terms of detecting and working out sort of the epidemiology and the testing surrounding this virus. So the first detection of the virus was December 8th. And that was in the seafood market, which a lot of people have probably heard about at this point in Wuhan. Very swiftly, though, the transmission started to move out of this market and sort of into the rest of Wuhan and the Hubei province. But this timeline is pretty amazing, I think. From the point of detecting it on December 8th to about a month later, there was just an enormous amount of activity, both in terms of reporting, which a lot of people, I think, were skeptical of whether or not reporting would really be made available coming out of China, and it was very quickly sort of sequenced, and the sequences were made public. And then by around the middle of January 11th, 10th or 11th or so, the gene sequences were public, and essentially PCR diagnostics were brought into the picture. So this was really just an extraordinarily accelerated timeline from relative to what we might have expected. You can go to the next slide. So just very briefly, the estimated time that this has been sort of estimated using essentially using genetics and the sequences from these viruses. Some of you may have already seen a lot of this. We can estimate that it was probably sometime in October to November is when it's most likely that this virus jumped into humans, at least based on the most recent ancestor. So I think there's a pretty good consensus that it was sometime in the fall, probably later in the fall, and sort of moved from there. And go to the next slide. There was a lot of question early on for anyone who wasn't sort of following it. There are all these conspiracy theories and things about where this virus may have come from, thinking that it was from a lab and it was actually bioterrorism. And so if you were paying attention sort of back in December, this was a lot in the news. But this virus isn't too surprising to see It's very closely related to other viruses that have already been detected that come from bats. So this is just to say, I think if anyone still had any residual doubts about where this virus is really originating and whether or not it may have been some sort of modified virus that came from a lab, I think that whole conspiracy theory has kind of been squashed, and this is really an anticipated virus, relative to some of the other epidemic viruses that we've seen, SARS and MERS being the most crucial. Go to the next slide. So this is to give a picture. Very early on in the epidemic, of course, it started in Wuhan, but then within a very short amount of time, spread was recognized to be moving out throughout all of China into many of the different provinces within really within January. There was which was just about a month or two since it really began, was sort of spread throughout the country, and then it began moving internationally pretty soon after that. So it was clear in January, I think, that there was really no way around this becoming a virus of international concern, and eventually it of course became a pandemic, and we are seeing the effects of that now. Next slide. So this, just to give an update of today, total confirmed cases are over 1.6 million. But I think what we're going to be talking about for the rest of this is really going to be about testing. And so this is just the confirmed cases. The actual reality is that we don't know how many actual cases there are. I think my bias will come out throughout the rest of this talk, that I believe that the number is easily tenfold higher, if not 100-fold higher in many countries. And then we barely have testing in much of the world. So the numbers could be just orders of magnitude greater than what we have so far confirmed in terms of testing. Next slide. To give some context for what this virus is, this is just a nice graphic that the New York Times posted a while ago. And just to put this in context for people who don't normally look at the epidemiology of viruses, there's this idea of R0, which is the basic reproductive number of a virus. And that's essentially, given a susceptible population, what's the sort of average number of people that any one person who is transmitting the virus might transmit to. And so you see the R0 value, that average number of people that it spreads to, on the x-axis there. And this is a nice graphic. So measles is oftentimes, you see that all the way on the right, it's oftentimes one of the most transmissible viruses we consider to be affecting humans. But there's usually some trade-off between the more transmissible the virus is. Oftentimes the rule of thumb is that it tends to be a bit less fatal or severe. And then on the other side of the spectrum, if you go all the way on the left side of this graph and up, you see things like Ebola and smallpox and SARS. And so that you end up getting to this other side of the spectrum where transmissibility is a bit lower overall. But the pathogenicity and the fatality rates associated with the virus tend to increase. And so the two of those, either you could have a very transmissible but not particularly fatal virus that transmits, and that's something like measles. And we can deal with that as a populace. It's not good when you have large outbreaks. It kills lots of people, but it doesn't tend to completely decimate populations, although there are stories and good evidence that it can. But on the other side of the spectrum, if you have a very severe virus that leads to a tremendous number of symptoms, then oftentimes those are a little bit less transmissible, and they're also easier to control if the symptoms are such that you can actually recognize individuals who have the infection pretty quickly. You can quarantine without a lot of individual testing required, and you're dealing usually with a smaller number of people because the transmissibility is lower. So this particular virus seems to have found a sweet spot between the two. This was sort of the type of virus that epidemiologists have been concerned and warning about for a very long time, something that has moderate severity in the spectrum of viruses, and moderate transmissibility. And this virus really did manage to find its sweet spot here, and a coronavirus is probably a good bet to be able to do that. And we're unfortunately seeing the effects of that now. Next slide. So the severity, probably people as well have seen this. This is a bit of an older slide at this point, although older means about a month old at this point. So the severity seems to scale considerably with age. The age demographic in terms of who is actually becoming infected tends to follow that. You actually have the majority of people will be in their 30s to 60s or 70s. In terms of overall case counts, at least those that are reported. And there's a tremendous amount of reporting bias if people are becoming asymptomatically infected. But then if you actually look at the mortality that we're seeing by age, over here on the right in the red bars, there's been some differences in the US that we've seen in terms of the ages. We see a slight increases relative to this graph in the US, particularly in the 30 to 50-year-old range. Those have been slightly higher. But really the most concerning thing, I think everyone is aware at this point, is the elderly and the most susceptible among us, the senior citizens in our population, elderly, and overall frail individuals. The mortality rate seems to be really extraordinarily high in these individuals. And comorbidities, things like cardiovascular disease, hypertension, chronic respiratory disease, are clearly interacting with susceptibility to this virus in terms of mortality rates. But we've seen really extraordinarily high mortality in the 70 and 80 plus age ranges here, which is why protecting nursing homes, protecting senior citizens has kind of become really what so much of controlling this epidemic is largely about. Next slide. So that was just to sort of lay some groundwork. The rest will really be about testing, and testing has been, the average person who never would have in their life heard about PCR is now familiar in some regard with PCR testing. And this is really the reason that testing starts with PCR for a virus like this is always PCR it's obviously anyone who's been in a lab that's done any sort of molecular biology knows that that PCR is sort of one of the core tools that is used in a molecular biology lab. And it's a technology that most countries should have access to. It can be scaled up to a certain extent to be able to perform in a lab without a lot of extra resources. And so one of the first tests to really become endorsed by the WHO was Christian Drosten's protocol. And this was a PCR test that was looking for 3 different targets in the viral genome, the envelope, RDRP, and the nucleocapsid. This PCR test sort of was and continues to be the majority of tests that are still being run by conventional real-time PCR are using the WHO test. And sorry, this was old. You can see I wrote hundreds of thousands of tests. That's much higher than that at this point in terms of the numbers of tests. Millions and millions of tests have now been run using that particular protocol. The CDC, on the other hand, developed in January, started developing its own assay, and a lot of this will get into sort of what went wrong there. We're still not actually sure of exactly what went wrong, but the CDC decided to take a slightly different approach and create also a 3-target test, all the primer probe sets were targeting the nucleocapsid gene. So in the US anyway, this test was initially sent out in early February to all the state laboratories. And at the time, there was a lot of fanfare around getting these kits out to the state labs, a lot of media attention. But in reality, and I'll go back to this, testing by that point was sorely needed. Cases were clearly entering into the United States. And the decision to distribute these testing kits to state labs, it was actually only around 700 tests per kit, with no timeline of when the state labs would actually be receiving a second kit. So there was a true limitation from the get-go in terms of these kits getting out into the hands of the state laboratories. both in terms of the speed at which it was performed, as well as the numbers of tests that ended up becoming actually available. Of course, very soon after those kits were sent out, laboratories in the state, during their validation process, started finding indeterminate results, started finding inaccurate results on their QC, on their quality control runs, and ultimately the CDC had to recall all of the tests back from the state labs, which essentially left the country with one laboratory, which is not a particularly high throughput lab at the CDC, able to actually process samples. So more or less throughout the entirety of February, there was almost no testing happening across this country, which essentially left us quite literally blind to what's happening with what was happening with regard to the spread of the virus. I'll come back again to this test on the next slide. But eventually, despite all the kits were eventually returned back to the states and state laboratories, and the decision was made to keep everything the same, but just remove the third primer probe set in the group, which is probably fine. The test seems to be working fine for the most part, but it did lead to this enormous delay when the end result was just the removal of a primer set. I think it led to an extraordinary amount of frustration amongst laboratory directors. Next slide. So these blunders really, I think, hampered U.S. efforts to detect this virus from the get-go. Throughout the whole of February, there were hundreds of tests when probably we should have been having already tens of thousands of tests being run in this country. We knew that transmission was likely already occurring within the United States. We knew that there were probably many imports, and without the tests, we just had no way to really figure that out and understand what was happening. But the big problems that happened were a little bit nuanced, but an interesting. It's somewhat of an interesting story, and some people may have heard of these three letters EUA, or Emergency Use Authorization. Essentially, at the end of January, the CDC, recognizing that this was a public health emergency of national concern, announced that it is a public health emergency. And what that ultimately did for testing was it puts in place, in this case, it immediately placed into effect the requirements for an emergency use authorization. And this is designed to protect the quality of the testing that's happening early on in an epidemic in this case. So essentially what it means is, to give reference, when a medical director normally, when they have a clinical laboratory in a hospital, the medical director who's in charge of that laboratory has usually very wide latitude to develop tests that are going to be useful for their patients. And so, for example, if I want to go and make a new influenza assay or a new prostate cancer assay or whatever it might be, there is no need for the laboratory in the hospital to go to the FDA and get approval for these tests. As long as they're being used for your own patients, it's part of medical practice that a pathologist can do that. So hospitals and hospital labs have wide latitude to do that. The declaration of a public health emergency set into motion a new requirement, and this isn't the first time it's happened, but it set into motion the requirement for any laboratory that wants to test even their own patients in a hospital had to get approval from the FDA. And the EUA approval process was very, very onerous. It's really calmed down, and I'll talk a little bit about that. But the EUA process and the notion of going through the FDA to get approval is usually something that industry partners do. If a company like Roche wants to create a new assay and start selling it to hospital labs, for example, they have to go through the FDA. And so this is sort of famously a famously onerous and difficult process to get through, and usually the FDA provides The good thing is that by the time these processes get through, these assays get through the FDA, you can pretty much count on them being accurate, good, solid tests that a hospital should feel good purchasing. But the idea that an individual laboratory would be then applying to the FDA was a pretty astounding bar to hurdle over to actually get a new test built. So essentially, what this meant was that the moment the EUA approval process was put in place, technically speaking, a laboratory could develop their own tests and start testing patients if they got EUA approval. But at the time, it was just far too onerous a task for most laboratories to be able to take on within the United States. And so what that meant is, so that left us throughout February with the CDC having recalled its tests from the state laboratories, and then the CDC having called this a public health emergency, putting in place the requirement for emergency use authorization, essentially left more or less no path forward for any laboratory in the country to be able to test anyone. And that with the exception of the CDC's lab in Atlanta. So it led to a tremendous backlog of samples needing to be tested, and it just completely hampered any testing that could be possible. So a lot of people ask why the EUA approval was in place in the first place. It's actually, I do think that it comes from a good position. I think it makes sense. The reason for EUA approval during a novel epidemic like this is because the cost of an inaccurate result early on in an outbreak is huge, whether that's a false negative. And if we just take, let's say, Ebola, for example, instead of this virus, it becomes more apparent why this is so important. A false negative result for somebody walking around with Ebola, it could be disastrous, of course, in the United States for somebody to spread it and go on the subway. So we want to make, so the idea there is to not have a false negative result. And also a false positive result is extraordinarily economically consequential and leads to widespread panic for a novel pathogen. So for viruses that are potentially containable, I think that it comes from, I think it's a good policy potentially. For a highly transmissible virus, the requirements for EUA approval, of course, just backfired here, and it hampered development of new assays. And so I can only speak from my experience. What we did as January was coming to a close, it became increasingly apparent that there was going to be a need for testing in this case at Brigham and Women's Hospital, at MGH, across the country. But we were sort of stuck. Not only was the EUA approval in place, but the fact that the CDC had recalled the test left us actually not knowing what we should do at all. Would the EUA approval ever be relaxed? And we also didn't know what test we should be building if we were going to build a laboratory developed test with the expectation that the EUA approval would become relaxed at some point. And that's because during February, there was also this astounding silence after the CDC recalled the state laboratory kits. Pretty much the only message was there's a problem. And there was just no explanation for weeks for laboratory directors to bank on. So then the question became, well, if we're going to build this test for a hospital, do we go with the WHO protocol, the CDC protocol, or something entirely different? Of course, being a laboratory in the United States, you would prefer to follow the CDC protocol, assuming that would probably have the least barrier later on. But without having any discussion from the CDC for weeks about what was actually going wrong, it really did leave a lot of questions on the table, and even and actually did hamper even the planning process of getting a test moving forward. Next slide. So even by the end of February, testing continued to remain just extraordinarily limited. At that point, the CDC was still only gearing up to expand the directive of who actually could be tested. So because of the severe limitations of the actual tests that were available, probably most people saw in the news that testing for a long time was really limited to people who had been in China or direct contact with individuals in China who had been infected. And that was really a feature of the test just not being available. Like I said, the FDA was still not approving lab-developed tests without an EUA approval. And I just think I was looking through some of my notes. On February 20th, I gave a talk about testing, and I wrote that it was likely that local transmission in the US will require considerably increased testing capacity. I think we probably know that there was ongoing transmission in February, and we just weren't testing it, but I think that was an understatement on my part. Next slide. So for anyone who hasn't seen a real-time PCR instrument, this is what the CDC protocol is based on, and it's based on running real-time PCR in sort of a conventional qPCR setup. The problem with this, and this is one of the big reasons why testing has been so slow to get rolled out, is that the CDC protocol, by utilizing that, by really pushing a qPCR, and I don't know that they had a different option on the table really, so I'm not faulting it, but it's not the type of test that would that's easily available to be performed within a modern day clinical microbiology lab. Most assays, I'll show on the next slide, are most assays that are available today in clinical microbiology labs, and what most of our technicians are used to using, are more sample to answer, sort of cartridge-based or simple to use, less manual tests. So the idea that we would be able to take a sort of raw materials and put them into the CDC protocol and get that into a hospital lab was very, very difficult. And in fact, the vast majority of clinical laboratories in this country could not actually be able to run this test, even if it were available to them at the time. And so even within Brigham, we have a very robust molecular biology group within our microbiology lab, but we are so reliant on the Roches and Hologics of and industry partnered tests that the expertise to run one of these assays within our microbiology laboratory staff was just not there. So at Brigham, we actually had to start combining forces where we would extract the RNA in the microbiology laboratory, because that's the BSL-2 plus area where we can deal with clinical infectious agents. And then that extract would go to the molecular diagnostics lab across the hospital that's normally doing cancer diagnostics and genetics, and because they had the real-time PCR instrument. So it became, even within a hospital like Brigham, which is a very highly resourced hospital, it was extraordinarily difficult to get over these hurdles. And continues to be, although now we've really changed the assay quite a bit. Next slide. So for anyone who hasn't seen some of these tests, these are some of the big players in terms of what tests look like in a clinical microbiology lab. And these started to become approved early in mid-March, which was an extraordinarily accelerated timeline. To give some perspective, usually companies that want to produce a new test and get it FDA approved, it will take over a year usually, if not two, and then it will usually take clinical laboratories months just to get it set up. So in this case, these companies really did all of their work within a month or two. And I recall at the end of January, or maybe it was the first week of February, I was on the phone with some folks from both Roche and Hologic asking, what was the plan for coronavirus? And at least at Hologic, which is a Massachusetts-based company that makes really tremendous instruments like the one you're seeing there, they still hadn't decided whether or not it was necessary to create a coronavirus test and whether it was going to be commercially important for them. And that was because there was just so little discussion here, really, I think, coming from our national federal level about how important a pathogen this was quickly becoming. And so that was as recently as the last week, or the first week in February, that discussion really happened. So what that means, though, is that right after that discussion, I think there was tremendous efforts being put in place at these companies to get these tests running. And now Hologic has 2 assays that are available. The Roche assay, you're seeing that big 6800 there. That's one of these instruments that Roche produces. It's actually a very, very large instrument. And you may have heard the President of the United States announce a number of weeks ago that Roche was going to be making millions of tests, and that was going to be that the testing woes in this country were going to be over. Of course, not surprisingly, the sort of next piece of this story, there was all the testing problems with the EUA approvals early. The end of that story was that the EUA has really relaxed. But then came supply chain problems. And that's what we have seen since these big companies have come out with their reagents. The supply chains for these, the demand has just extraordinarily outstripped the supply. And these companies build tests for the entire world. So it's not surprising that the supply chain would become a major factor here. And right after Roche came out with their test and said that each of these instruments could be running anywhere from 1,000 to 4,000 tests per day. The important thing to know is that any laboratory that has one of these big instruments is probably utilizing that instrument for a lot of different tests as well. So that was kind of a disingenuous discussion about the true throughput, which would really be more in the hundreds for when they were saying thousands. And this led to a lot of confusion, I think, in the country. People were assuming that they'd be able to get tests available, but really weren't. More recently, we've seen Cepheid and GeneXpert, as well as QIAGEN, and the most recent was the Abbott ID Now. These are really simple to use cartridge-based assays. These are true sample to answer. You take a swab out of somebody, more or less. There's a little bit of work, but you put it into a cartridge, throw it into a machine, and it gives you an answer. So these are very, very nice instruments to use. They can be very rapid within minutes. The Abbott ID Now is actually under 10 minutes. Problem is, these are extraordinarily highly manufactured tests. So the more manufacturing that needs to go into each individual test, the harder it is to keep up with the demand, and the supply chain really slows down. So the Roche and Hologic, they essentially send out bulk reagent, whereas Cepheid, QIAGEN, and Abbott Now, they are these little cartridges, and they can only produce so many of them at once. And each of those companies has really run into enormous supply chain issues. And so we're still seeing that testing remains a major limitation throughout this country. On top of all this, so now that testing has become somewhat more readily available, a very weird twist in this whole story is that now actually one of the most limiting features across the globe has been the availability of the nasopharyngeal swab. This is a small little piece of plastic. It's about 20 cents to purchase each one, and the real problem is that these came from, there's very few manufacturers in the world who are usually making these for the globe. One of them, one of those manufacturing plants is based in Lombardy, Italy. And this is a company called Copan. And as you may have heard in the news, Italy was hit extraordinarily hard by this epidemic. So that one plant where these swabs are being made really was hit hard as well. So there was both this enormous demand for their product at the same time that their employees were becoming ill, and the company was having trouble actually getting the manufacturing done as per usual anyway. So it really became sort of a perfect storm. And today we are still truly at a loss for these swabs. A number of individuals, Deb Hung and myself and others, have been working with other folks to sort of get back channels into Chinese companies who can ship us swabs. The owner of the Patriots recently sent a jet to China to pick up swabs and other PPE supplies. So it's really just been this amazing interplay with the global supply chain and testing that has become, maybe movies at some point will be made about it. Might be very boring movies, but it's been interesting to see. Next slide. So looking forward, I think, so that was a lot of PCR, and all of those tests I was just talking about were some form or another of PCR or isothermal amplification. We're also seeing, I think we're going to see a lot of new tests. And one of the interesting things about this, this epidemic is that it's really driving forward innovation, and it's accelerating processes that normally take years and years and years to get going. Some tests are now being, and whole new technologies are being put forth and potentially utilized. New collaborations are being built between industries, and so this is just one example between Sherlock Biosciences and Cepheid, or a couple of months ago, or maybe last month, have some sort of partnership. I'm not sure the details, but to try to build Sherlock into Cepheid instrumentation. So we're going to be seeing a lot of these, what I call pregnancy test models. These are rapid diagnostic tests that can look for the pathogen in a lateral flow assay. And there's going to be, there was a recent Evergrande call for RFAs for applications for funding, and enormous numbers of applications probably flew in, for all looking at different rapid diagnostic tests. So in Boston, the amount of innovation has been really very extraordinary with the numbers of people who are working on this. And I think that when this portion of the epidemic comes to a close, I think we will be seeing a lot of new technologies that become available. Many of them may start in developing countries where a lot of these lateral flow assays might have the most use because of a lack of central laboratories. But we'll have to see sort of what happens there. Next slide. And so looking forward now, we're really going to see the rise of antibody testing. People have probably heard a lot about this. The antibodies give you a history of infection. They could potentially provide a diagnosis if you can get early enough IgM detection. But really, these assays are going to be able to give us a snapshot of what has happened. And the important thing here is that we still don't know at all, I would say, how many people have been infected. And that's because of the lack of testing that I've been talking about. So antibody testing, if we can roll it out to a large enough population and in clever ways to really get representative samples of the population, we can pretty quickly start to get a whole new view of what course this epidemic has taken. And until we get some of these early serological studies, we really don't know where we are within orders of magnitude in terms of the numbers of people that have been infected. If it's truly within the low hundreds of thousands, like we have in the United States reported so far, then that's a very, very small fraction of the United States, and it means we have very, very low population immunity. If, on the other hand, we've already had 10 or 15% of the population infected, it completely changes the course that we take next as a populace. And so I'll come to that in just a moment. So antibody testing is going to be increasingly important, and we'll see the rise of these lateral flow assays. These are, again, like pregnancy test type of models where we can detect just at home. Potentially you take a finger prick and put it on one of these, and it will tell you if you have antibodies. Next slide. You can keep going. And so this is just, these are a couple of pictures of some of these assays being used. And then there's actually this very, very new sort of what's called a digital ELISA, which David Walt's group has been experimenting with. And digital ELISA is sort of, it's actually single molecule detection. So there's a lot of hope that maybe some of these single molecule detection systems, there's not many of them in the world, this is maybe the one, called the Simoa from this company Quanterix. These can potentially detect single antibodies that are elicited, for example, IgM, maybe within a couple of days of infection. So there's a possibility actually that using antibodies could actually become a true diagnostic rather than just looking back in somebody's history. Next slide. So I think just I put this little stat thing there, just that was February 25th. And even then, CDC was just saying that they expect some community spread of coronavirus. I think that epidemiologically, it was apparent that there was clearly community spread, but the federal government was pretty slow to act, as I just went through. But I think of February and March as sort of the month of PCRs testing in the United States. And now we're really entering into this new phase of the epidemic where April and May will usher in sort of the next phase, which is going to be a tremendous amount of serology, and PCR and antibody testing will be crucial in the future in terms of understanding the dynamics of this virus and detecting outbreaks. And certainly the answer, at least just to the initial point prevalence questions that we're going to be asking using serology and population studies, it really is going to dictate what steps we can take next. If we find that only 1% of the population has truly been infected with this virus by the end of this outbreak, by the end of this portion of the outbreak, then we're going to really be in a rut. That's going to mean that this virus is as severe as some people fear, and we're going to have extraordinarily low population immunity, which will mean that our options are extraordinarily limited in terms of how to get the economy moving. On the other hand, if we get our first serological studies back and they show that we have 15% of the population has already been infected, that's still not sufficient for good population herd immunity. But what it would mean is that we will have that the actual infection mortality rate and the severity of infection amongst the vast majority of people who get this infection would be much lower than we are currently thinking. And so it could be that within the United States, we have 20 million people who are infected. And if that's the case, then the mortality rate is not tremendously high. I think it's still obviously a very severe virus, particularly for elderly. But at least it starts to paint some picture or some path forward for getting the economy moving, probably leveraging demographic quirks of this virus, that the silver lining is that it's not infecting the youngest among us very much at all in terms of severe disease. There's been very few deaths of young children. And so what it means is if it turns out that a huge fraction of the population has already been infected, we can start to consider ways that we might be able to get the economy moving while still being absolutely careful to protect the most vulnerable people. And so until we get those first prevalence studies, I think we're a little bit bound in terms of making really rigid decisions about what we do next. So I think that's where I'll stop, and I'll just ask if people have questions for a few minutes.
Michael, let me start out with a few, and then we'll open it up to the audience. The first is, you began to allude to this at the end, and this notion of how do we get back up and functioning as a society. And you hear a lot about the need for tests. Can you expound on your thoughts of the role and how one would actually use it, and how one would distinguish, exposure, meaning that, you have IgG and antibodies versus you're actually protected. Mm-hmm. And, what is the experiment that you would want to see to be convinced of protection?
Sure. So that's a huge question, and it's one that I think has been, I think amongst scientists and immunologists, it's being thought about very critically. But there's been a lot of hope by policymakers and decision makers that now that we have serology, we'll know who has been infected, and anyone who's been infected with an IgG positive result can go back to work. That is not the right answer right now. We don't have the right evidence to know if having an antibody response and an IgG positive response actually implies that you are fully protected. We anticipate that this virus won't be tremendously different from other viruses that humans get exposed to. And so we expect that there will be some level of protection for the individual against severe disease if they've recovered recently. But one of the major questions that's completely unknown is whether or not somebody who has an IgG positive response, whether they can actually acquire the virus again, and even if they don't get sick, if that virus can replicate and allow them to serve as vectors and transmit it. So the idea that we would be able to just take an IgG positive person and throw them back in the hospital, or take a nurse and put them back in a nursing home, for example, would be a very bad choice to make without really thinking it through. And so the studies that are going to have to be undertaken will be difficult, but they're going to be studies where, for example, we look at high-risk individuals, and this would just be for power. We might take individuals who are in a hospital, doctors, nurses, janitors, whoever they might be, people who are getting exposed a lot, follow them in time longitudinally, and then and take their antibodies and check for a virus in their nose. If they get infected, then you put them in one cluster of people and you compare them to other people who have not yet been infected and follow over time to see, will they get reinfected? What's the relative rate of them getting reinfected? But you also will have to be swabbing them on a regular basis because they might not be symptomatic if they get reinfected. So there would have to be some way to actually detect whether or not a virus can come back into their nasopharynx, replicate, and potentially transmit. So in some ways, this is even going to potentially require new tools for actually being able to detect if somebody's shedding. PCR can do that okay. We can look for the viral genome in somebody's nasopharynx, but ideally we'd want something that could actually give us a better readout of shedding. And the other piece is that maybe we will find some correlative protection, but the studies will also in that same vein have to take the antibody serology tests, these quantitative values, and see if there are thresholds of protection that could help people that could actually indicate that you're truly protected versus a lower antibody titer where somebody might not be so protected. And these are the unknowns that continue to plague us. They're unknown actually for many, many viruses. And this is, there's a lot of studies that are getting started to explore this, but I think the real point is that policymakers and others and employers who are looking to get their employees back to work, I think it would be too early and premature to think that these tests that are coming out now are going to be the end all be all for deciding who can come back to work.
I guess related to that, right, the notion of the pregnancy test equivalent, how do you imagine that actually being used? You know, what is their role? And if one imagined at an extreme, it was actually rolled out directly to the public, you know, do you worry about people, you know, misinterpreting the results? Say, oh, you know what, I'm positive, therefore I'm safe and I can go out and engage the society again.
Absolutely. This is why, you know, for one of the major features of laboratory testing is, whether it's for HIV or whatever it might be, testing results are not usually given directly back to a patient without also some sort of consultation with a clinician, because there's lots of room for misinterpretation of the results and what it means for somebody. And so in this case, getting a positive result for IgG will not, you know, I think that there's a tremendous amount of room for misinterpretation there. We don't want individuals out in the community. There's a lot of community studies getting going, and there's a lot of point of care pregnancy model tests, both for the virus, but also for the antibodies. And these are being sort of, a lot of these were developed in China and Korea, and sort of they were blasted into our populace in Europe and in the United States to try to sell direct to consumer, get them through the FDA quickly. And they're turning out to be inaccurate. So a lot of them, and so the inaccuracy is obviously a problem. If you're getting false positives, then somebody could have a false sense of security that they are immune. And if you have false negatives, obviously that's also a problem that you might go and transmit. But the other problem is exactly what you're getting at, Deb, which is that people might not interpret these properly. And if we just blanket the population, on the one hand, if we blanket the population, everyone gets their results through these individual tests, it would be that data often won't be able to make it into public health databases so that epidemiologists and public health officials can monitor the situation of this virus. So we need to figure out some clever ways to, if these point of care instruments are going to people's homes directly, to ensure that there's some mechanism to get that reporting to the state laboratories or to the departments of public health so that the epidemic can be monitored. But we also need to make sure that the messaging surrounding what these mean is extraordinarily clear. And we really can't make that clear until we have the science. So I think sending these directly to consumers now does pose somewhat of an exceptional risk in terms of how they'll be interpreted. We don't want, for example, for the populace to start rushing back out right now and stopping their social distancing. We absolutely need to continue social distancing for at least another month or two before we can really even think about it, about going back to sort of some semblance of normalcy, because we need to get this virus under control. And the risk of people getting tested and saying that they're fine and then going out without masks and rushing back to work is very high, in particular in a country where people are very antsy to get back to work. I think any glimmer of hope will cause them to try to do that. We need to just be very careful with these things.
Michael, just to provide context for folks, can you just let folks know the window in which the viral testing tends to be positive in patients, and then the window in which you actually see antibodies formed, and then maybe a quick comment of just what the lateral flow test is that people are talking about as a pregnancy test?
Sure. So the window of positivity, usually people will start to become positive within a few days of infection, maybe 4 or 5 days. You'll start to really be able to detect the virus in their nose. And then some people will remain positive for quite a while. So for a couple of weeks, perhaps, you'll still be able to detect viral RNA in the nasopharynx. And so, but essentially the highest titers will usually happen within the first week of infection. And then there will be sort of a slow clearance of that virus. During that period of clearance, within about a week or two, you'll start to see IgM antibodies come up within the first 10 or so days. And IgM antibodies will usually indicate that somebody's had a recent infection because they come up pretty quickly. And then there will also be IgG antibodies that will persist longer and sometimes for life. Those will come up about a week or 2 or 3 later in the course of infection after IgM usually arises. And there's some windows here that change depending on the individual, but IgG usually comes up a bit later and then persists. So it's a very good indicator of past infection. If you only have IgG and no IgM, then you can start to infer that maybe somebody had it, maybe a month or 2 prior, and the IgM has already disappeared, but the IgG has lasted. So these point of care pregnancy test model instruments that are going to probably become available soon to consumers, these are going to they'll probably have both a line for an IgM and an IgG response. So people will be able to see on this, do they have an M or a G, neither or both? And if you have both, that means you may actually still have, it could mean if you have IgM that you still have virus inside of you. And so if they're sufficiently sensitive for IgM, it could be used as a diagnostic tool to tell people, hey, you might be shedding. Maybe there will be some kits that come with both a diagnostic for the virus itself and a diagnostic for the antibodies. And I could see those being packaged together to consumers so that you could swab your nose, put that into solution, put that on one of these tests for the virus, and then also prick your finger and put the antibodies on the other one for testing for IgM and G. So they'll both probably work in concert, and I can already picture sort of all these companies coming out with these, and that there will be a lot of utility, I think, if we can assure that they're accurate and learn how to interpret them. I think as the fall comes around and we start to deal with sort of a second wave of this epidemic, which is sort of being expected epidemiologically, these types of tools might become crucial if you can get lots of them out into the community. It might be that people buy kits of 10 of them and use one every week, especially if you're going to go and visit your parent in a nursing home, for example. You might want to swab yourself beforehand just to make sure that you're not potentially transmitting and bringing that into a nursing home. So there will be utility, but we have to ensure that the information is accurate and people understand what these results mean and what it means they can or can't do.
Michael, significance of shedding in stool?
So we don't know yet if stool actually has viable virus. There were some early thoughts that maybe the thing is that this virus binds to a receptor called ACE2, which is actually an incredibly important receptor that's part of our sort of cardiovascular system and our renal system. But the ACE2 receptor, and where the virus can both replicate in the lungs and in the respiratory tract, but it also happens to replicate very well in the GI system, in the stomach and the intestines. And that's why a lot of the people who have symptoms actually are getting GI symptoms more so than even respiratory symptoms sometimes. And so we know now that there's a lot of virus that replicates in the GI tract, and it can shed into the stool. So actually, I think stool will become, whether it can be transmitted through the stool is unknown in terms of a fecal oral type of route. But stool could become a very useful tool public health-wise to be able to monitor it in wastewater and sewage. For example, you could actually monitor populations by looking for viral RNA in the stool from this virus. And I think that there is a possibility. It could even be that direct, stool sampling from individuals isn't the most convenient or pleasant for people. So I don't know that stool sampling will become a big thing that individuals will sign up to do. But there are a lot of people who do microbiome studies, and I could envision kits being sent out to people's homes for surveillance. And that good thing about stool is the RNA seems to last quite a bit longer in the stool than in the respiratory tract. And it's not certain. We don't know if that's viable virus or if that's just residual RNA that's been that has a slow sort of excretion in the stool. And I think there's going to be a lot of research into understanding what it means to be RNA positive in the stool.
Okay, because of time, I'm going to just ask one last question. And you may or may not have insight into this, but I'm going to let you take it on anyway. A lot of people want to know if the WHO test was available. What was the thought process behind the CDC needing to generate their own?
I don't have personal insight into the CDC's thought process. I think that I can take some guesses, and I think that there's this idea that we're America, we do it better or something. And, I don't know that that's where the idea came from, but I do look at the notion that there was the WHO assay was working well. There was no problem with it. I think that there are a lot of people in the world who were using it successfully. The idea to roll out a whole new assay that's a single gene, 3 target, but still single gene assay, versus the WHO assay, which is looking for 3 targets and 3 distinct genes. I don't know what really led to that decision. I could see one benefit of it was to have the controls. You only have to make you only really have to make a single gene construct, but we can concatenate all these genes together. So I don't know that that's a good reason to do it. I don't know, to be honest. I've been critical of the decision to not use the WHO assay. I think it would have, in particular, the moment that the kits had to be recalled, there was such a long delay in figuring out what went wrong and messaging to the communities in this country what was wrong with those kits. I personally think that the decision should have made that day, the moment they started seeing problems with the CDC kit, to just say, okay, we're moving to the WHO kit. It works. There's no reason to not use it. And I still don't see a reason why we aren't using it today. And there's even been some decent studies that suggest that it's more sensitive and the primer design might be a little bit better. So it's hard to know what went into that decision.
The CDC test was later. Could it have been based on more genomes available, greater sequence conservation?
It could have been. I don't know that I would pin it on that.
Okay. All right, many more questions. Unfortunately, we're out of time, but thank you, Michael. Thank you for everything that you've done, not simply in giving this talk, but really trying to mobilize the whole community to take on COVID diagnostics. Greatly appreciated.
Absolutely. And before people, I would make a plug for the Broad, since this is being sponsored by the Broad. The Broad has really taken on this tremendous effort for the state. If you haven't read about it, the Broad Institute, in the midst of all of this the testing woes, decided to turn its attention to trying to help out the community in the state. And it's really become a massive success to get testing more available for Massachusetts and for New England more broadly, by essentially taking the genetics platform and the efficiencies of automation that the Broad has developed over years, and essentially turning their attention and all of that whole platform to testing for this virus using automated platform and real-time PCR. And it's been tremendous support for the state laboratory of Massachusetts and other state laboratories, including Vermont. And then a lot of other hospitals are now sending their samples to the Broad Institute to actually be tested. And so I just want to put that out there, that it's been a pretty incredible effort by all the folks at the Broad who have been involved. And I think everyone in the region thanks them for that.
Thank you, Michael. And thanks for everyone for joining. Stay safe.